Oh, here we go. So anyhow, so I'll give you a little introduction to this program. We'll talk about everything to do with ARVD, but I'm going to start with a story. And like with you, I'm basically a clinical EP guy. You know, I like doing cases, like seeing patients, and you know, I also find research sort of interested, but I've never gotten an NIH grant. I get all my funding from donations from patients and just do it on nights and weekends. And all my focus has been sort of patient-based. But this whole interest in ARVD really started with this patient, Carrie Campanella Becker, who I saw in March of 1997. And I was seeing, she was referred to me by Tom Guarnieri, who used to be the head of EP here. And he had diagnosed probable ARVD and referred her to me for a second opinion. So she was a 35-year-old woman. She had had syncope. She was a big horse kind of person. Her physical was unremarkable. As Ron Berger likes to say, a stethoscope's just part of our uniform as an EP, so I can't tell you much more about that. But her family history was interesting, that her father died suddenly at the age of 36. And it turns out her father was a guy named Joe Campanella, who was a professional football player with the Baltimore Colts. And he died suddenly playing squash with Don Shula. And it was written off to a quote unquote a heart attack. An autopsy was never done. But that was interesting. So here is her EKG. You can notice the T-wave inversions V1 to V4. And if you look in V1, even I would call this an epsilon wave. You know, an epsilon wave has to be distinct from the QRS complex. So you drop a perpendicular from the latest QRS complex V1 to V3 down, and it has to be after that perpendicular separated by an isoelectric interval. So I would call that a true epsilon wave, but we'll get back to that a little bit later on in the talk. But clearly her EKG was abnormal. Her MRI, she had a big right ventricle. She had an EP study, a lot of inducible VT. I said, yes, you have a defibrillator. You know, Tom had gone into private practice. I didn't want to steal any cases from him, so I told her to go back to Tom and get a defibrillator put in. And it turns out the patient elected to wait till the end of the summer to have the defibrillator implanted, and she didn't make it. She had sudden cardiac death getting off her horse about a month or two after I saw her, and it really was a catastrophe. And I remember taking that call as I drove up to northern Michigan to our summer place. So before you know it, I ended up seeing her youngest brother. Her youngest brother wasn't born when his dad died. He was born, you know, after his dad died. He's like the 6th or 7th Campanella in the family. And this is John and his wife, Kathy, and they had been newly married at that time. And John had some palpitations. Kathy was very nervous about marrying damaged goods. And they ended up coming to see me about, could he have this disease? So this is John's EKG. And you can see he has some T-wave inversions in, you know, V3 and V4, biphasic and V2, not totally normal, but not classic for ARVD. But, you know, I thought this was a little suspicious. Did a Holter, was quiet, got an MRI, had some sort of slight evidence of this or that. Did an EP study, was non-inducible. And we tried to figure out, well, should he get a defibrillator? His dad died suddenly, his sister died suddenly. And the bottom line is we ended up putting in a defibrillator, mainly because of this terrible family history and not knowing a lot back then. And I talked to Frank Marcus, who really is the pioneer in ARVD, and he had told me you should tell these people not to exercise. So I told him not to exercise. And now 22 years later, he's doing great. He's never had a defibrillator shock. His defibrillator's been replaced multiple times. He remains non-inducible. He has a couple kids. And lo and behold, we identified the plakophilin 2 mutation in him, and that's the most common mutation you find in ARVD patients. So this is his EKG in 2016, and you can see the zero progression. And, you know, basically everything's been absolutely fantastic for John. So that's sort of a happy story. So back in 1997, you know, the question was, you know, we didn't know much about ARVD. How do you make the diagnosis? What's the natural history? Does the disease progress, and what causes it to progress? What should you do about exercise, medications? How do you risk stratify people? You know, should everyone get a defibrillator? It was known, it was sort of familial, but no gene had been found at that point. And, you know, and then obviously the big goal was to try to cure ARVD. So John and Kathy ended up, they were sort of smart people from pretty affluent families. So they went around the world seeing everyone working on ARVD. They flew out to Arizona, saw Frank Marcus. They flew over to Padova, Italy, talked to Gaetano Tieni and Domenico Corrado. And they flew back to Baltimore and said, there's not much going on. I think we should start a program to focus on ARVD. And I thought that was fantastic. And I felt terrible about that patient who I felt that I probably should have put the screws to her a little harder to get that defibrillator put in. And so I was hoping that they were rich and could write a big check, but turns out football players in those days didn't make a lot of money. But we decided to start the program. Kathy started this website, ARVD.com. And with that, the program was launched. And one of the crucial things was getting some money. And John was smart enough to figure out that Jack Bogle, who founded the Vanguard funds, had been transplanted for ARVD. So the next thing you know, me and the president of Hopkins University and the head of cardiology, Ken Boffman, are all meeting with Jack Bogle down at Hopkins. And he pulls out his checkbook, wrote me a check for $1 million or $1.5 million to start the fund, start the program. And he specifically said, I want you to use this money. Don't use it as an endowment, but spend it as capital to get the program launched. And with that, the program started. And the first person we hired was a genetic counselor named Julie Rutberg. And someone at church had recommended that we hire a genetic counselor. I didn't even know these people existed. And the second person we hired, our first research fellow, was Harry Tandry, who's now one of my colleagues, and I've been working with ever since then. And Jack just died last year of esophageal cancer, but he had a very long and happy life. And he's an amazing story. He had showed up at Princeton. He went to Princeton as a scholarship student. He would wait on tables at the eating clubs and stuff like that. And then obviously became a fabulously successful investment a banker, but I'm very grateful to Jack and his wife Eve for helping us get our program going. So we started the program, and the goal was to work with the whole international community to educate patients and physicians about this disease, to coordinate care of these patients, and to learn new things. And last year we celebrated the 20-year anniversary of the program. We had a big symposium. These are the folks that attended from all over the world. And it was lucky it wasn't this year. The whole damn thing would have been shut down. But we had a great sort of celebration of sort of where we are now and where we're going. So let's talk a little bit about ARVD. So it's an inherited cardiomyopathy. It's characterized by progressive replacement of the right ventricular myocardium with fatty and fibrotic tissue. The key is really myocyte loss with fibrotic replacement. The fat is very nonspecific. And fat in your heart really means sort of nothing. You can have fatty hearts. You can see fat in an MRI. It doesn't have much to do with the diagnosis. It's about myocyte loss and fibrosis. Arrhythmias we know about, and it's a very arrhythmogenic condition. We also know there's a left dominant form, or biventricular forms of the disease are quite clear now. This is a 32-year-old patient we transplanted for ARVD. You can notice the RV is blown out. The LV looks pretty good. There's some a little bit of sort of fat infiltration here, but again, look at the right ventricle with the myocyte loss. It's fairly striking. When you look at the history of the disease, Gaetano Tieni will tell you it's been known about in Italy for more than 200 years. But the group that put it on the map was Frank Marcus and Guy Fontaine. And Guy Fontaine also died last year, the year before, a real pioneer in the EP world and just an unbelievably sort of eccentric but genius guy. But Frank had a sabbatical, so he went over to work with Guy, and Guy ran a big DC shock VT ablation program. Had been seeing these strange patients with this RV myopathy. And Frank wrote up that series, and this is the first sort of major paper on ARVD. And that paper was a beautiful paper, but it had one big mistake, and that's this figure. So this figure shows the triangle of dysplasia. And they're trying to emphasize that ARVC impacts the inflow tract right under the tricuspid valve, the outflow tract, and the apex. And I say it's a mistake because ARVD doesn't involve the apex. Only when your whole RV is dead is the apex involved. With early disease, you never see apical involvement. And that's led to a lot of overdiagnosis, misdiagnosis, because in those early days, people would look at the RV apex and it looks a little thin. Maybe it's not moving normally. Is this ARVD? And a lot of patients were overdiagnosed. Turns out the third leg of the triangle is the posterolateral LV is the other sort of area that you look for. This is just shown here with a reference from 2013 when we put this together. So it's a pretty rare condition. We say it's 1 per 5,000, but where that number comes from, it's really picked out of a hat. I think it's sort of made up. But the point is, if hypertrophic cardiomyopathy is 1 per 500, this is about 10 times less common than HCM. It's slightly more common than men and women. Men do worse than women because testosterone's a bad actor. We'll get to that. Counts for about 20% of sudden deaths and about 5% in the US. It's about the number 3 or 4 sort of cause of sudden death in young people. Now, this is a recent paper by Chris Samsarian, looking at, the cause of sudden death in young people in Australia. And you can see it, it's a more common cause of sudden death than HCM, even though HCM is 10 times more, more common. The other thing you got to be aware of, the diagnostic criteria, these were put together by Frank back in 2010. They're good, but they're imperfect. And there's been some efforts recently to update them because now it's 10 years later and the world's sort of starting to think about that. And I would guess in about 2 years, we'll be done with a new diagnostic criteria. But for now, we're left with these. And you have the 94 criteria, the 2010 criteria. It lists, you have RV size and function. It's quantitative biopsy. They give specific percent normal myocytes. T-wave inversion, V2 and V3 is a major criteria. It's very easy to diagnose. If you have just V1 and V2, it's a minor criteria. Epsilon waves are listed as a major criteria, but I'm going to encourage you to ignore those, and I'll go over that a little bit later. Signal average EKG is still part of the diagnostic criteria, but we never do signal average EKGs anymore. We found them to be very insensitive and nonspecific and of basically no value. TAD, terminal activation delay, is the time from the tip of the S wave back to baseline. And that sort of replaced the signal average EKG. The cutoff is 55 milliseconds as a minor criteria. Left bundle superaxis VT is a major criteria. If it's left bundle inferior axis, it's a minor criteria, more than 500 PVCs, and then some family history and genetic result criteria. So here's another EKG of an ARVD patient. T-wave inversions V1 to V3. And then look at this TAD. This is what I mean. The tip of the S wave back to baseline, more than 55 milliseconds. You can see it sort of sluggish getting back. That's the slow activation of the RV. You can see it here too. It's some people would say this is an epsilon wave, but an epsilon wave has to be distinct from the QRS complex in V1 to V3. And if you draw a perpendicular from here up, this is within the QRS complex. It's delayed activation. But anyhow, so that's another EKG. An MRI showing ARVD, and Harry Tandrew, sort of the world's expert in MRI reading. So it's important to remember that, the MRI is one of many diagnostic tests. It's not the gold standard. It's the most common reason for overdiagnosis. And we've taken out about 25 defibrillators of misdiagnosed ARVD patients. I think we just published a recent series. But the reason, it's sort of embarrassing, you put a defibrillator in, then a patient comes and sees us for a second opinion, we take out the defibrillator. We had one patient who came down from Philadelphia with a newly implanted defibrillator, and we told him he didn't have ARVD, and he was sort of horrified because he just got the $60,000 bill the day before. So he went out to the Cleveland Clinic to get a second opinion, and they took the defibrillator out. So the most common reason for overdiagnosis is people aren't aware of the diagnostic criteria. They don't recognize that myocardial fat and wall thinning are not part of the diagnostic criteria. You may have, quote unquote, a thin wall. That's not part of the diagnostic criteria. Fail recognition that RV wall motionalities may result from an RV free wall tether or a pectus. If you have an ARVD patient and they have a deep pectus, probably that screwed up MRI is because of crazy motion because of the pectus. RV moderator band's another reason. And people were also focusing on the apex of the RV, thinking that was part of the triangle, not knowing it's not. And then that would make them think, oh, this must be an ARVD patient, and they'd throw in a defibrillator. So let's move on to the genetic basis of the disease, which is a fascinating story that starts in the island of Naxos, which is about a 2 to 3 hour ferry ride from Athens. I've never been there, but I'm planning to go there at some point. But anyhow, on Naxos, there was a physician couple, Nikos Protonotarius, who's now dead. He died of GI cancer, and his wife, Adelena, who he had grown up on the island. And when he graduated medical school, they went back there and set up shop. And they noticed these strange patients that would show up with this woolly hair, palmoplantar keratoderma. They would say you could make the diagnosis by shaking their hand. And then clinically, they'd show up with what looked like the ARVD that Frank and Gia described. They had this fibrofatty replacement in their hearts. They had all these arrhythmias. So when this was termed Naxos disease, and they'd go to the beach and they'd see someone with this screwed up hair and funny palms, and they say, why don't you come on in for an evaluation? And they'd find this. Anyhow, it was a remarkable story of how they put this paper together. They actually hand delivered it to the British Heart Journal. They flew to London to deliver the paper because they were suspicious of the mail, and sort of an amazing story. But they discovered this. And once they discovered Naxos disease, which is a disease of the skin and the hair, they'd say, well, that must involve desmosomes, that got people thinking about desmosomal proteins. And then 14 years later, Godfrey McCoy was a PhD student, went to work with Bill McKenna. They got all the blood, and they ended up discovering that plakoglobin was the cause of Naxos disease. And once that was discovered, people said, well, what are the other desmosomal proteins? And they quickly, within 5 years, all the mutations were found. So that was 2000. 2002, desmoplakin was discovered. 2004, plakophilin 2, the most common one, was discovered. 2006, our group discovered desmoglian. That was confirmed by another group. So very quickly, all the desmosomal proteins were identified as causes of ARVD. And these desmosomes are the bolts that hook myocardial cells together. They're these linker proteins. Some are intercellular and some are intracellular and whatever. So as of now, we know you can find a mutation in about 2/3 of patients. Plakophilin 2 is the most common, then desmoglian, desmoplakin, desmocolin. Plakoglobin is pretty rare. There's some non-desmosomal proteins you rarely can see. TMEM43 is the Newfoundland version of the disease, very penetrant, very lethal. Ryanodine receptors have been identified in some patients. And then you have things like phospholamban, which is the foundry mutation they have in the Netherlands that causes a condition that sort of behaves, looks like ARVD, but doesn't really behave the same. For example, exercise doesn't impact the phospholamban version of ARVD, filament C, and so forth. And these together probably represent about 5% of patients where you can find a mutation. So inheritance of these desmosomal mutations is predominantly autosomal dominant, with age-related incomplete penetrance and variable expressivity. Patients could have multiple mutations, 2 mutations of one gene, or multiple mutations in 2 different genes. And in general, if you have multiple mutations, you do worse. And in about 1/3 of patients, they're gene elusive. We can't find a cause. So then we move on to what causes ARVD. And you have the simplistic cause that I like to think about. You have bad bolts or bad glue, you exercise too much, these desmosomes get stressed, they pull apart, they die, and you get fat and scarred. That's the simple way of thinking about it. And then you have the way people like Jeff Safitz likes to think about it, the scientists. You have these desmosomal gene mutations that causes nuclear signaling of Wnt and other nuclear signaling proteins. And that turns on apoptosis and fibrogenesis and adipogenesis and transdifferentiation of myocytes. Turns out it's very, very complex. And people like Mario Delmar, Jeff Safetz, have made a career studying this, and it's fascinating, but it's something a mere clinical EP guy can't fully comprehend. But I can't comprehend a lot about clinical presentation and follow-up, and we'll move on to that. So here's our first big series in 2005, 100 patients, 69 diagnosed while alive, 31 on autopsy. We called this paper, a United States experience, because prior to that, people thought this was a disease that only occurred in Europe. It was sort of like the virus. We thought it only was over there in China, but it turns out it's everywhere. And, you can look at this. The average age of patients around 29, half are men, half are women. A lot are athletes. Show up with palpitation, syncope, or sudden death. Some are asymptomatic. Now, this shows sort of a Kaplan-Meier curve. Symptoms correlate with VT. Sudden death less common. Heart failure is late. But this disease doesn't occur before puberty. You never see anyone younger than 12 or 13 or 14. It's really around 13, 14, 15 it starts to show up with the average age of around 30. This is a transplant series we put together a number of years ago of patients who were transplanted. And the point of this slide is that patients show up and they end up getting transplanted about 20 years later. So the symptom onset was 24. The people that end up needing transplants usually show up at a younger age. And it's about 16, 20 years later that the heart fails, they end up needing the transplant. And they're transplanted mainly for heart failure, less for arrhythmias, because we've gotten so good at handling the arrhythmias with catheter ablation. So recently we updated our experience to 1,001 patients and family members. This is working with our colleagues in the Netherlands who we partner with in a lot of our research. And it basically confirms what we showed in that first series. Patients show up. If you have a gene, that you show up a little bit earlier than if you don't have a gene. The main manifestation are arrhythmias, heart failure, and transplant, occur, late in the condition. We've also done studies on genotype, phenotype relationships. This is one paper of 577 genotype patients. Plakophilin 2 is by far the most common. These are all patients with a mutation, and all the other ones are pretty uncommon, and they can be different types of mutations. So there are a couple findings from this study. The first was that patients presenting with sudden death were younger than those presenting with sustained VT or asymptomatic patients. So if you presented with sudden death or were asymptomatic, you tended to be younger. There's sort of a hot early phase of the disease. Patients with more than one mutation presented earlier than those with a single mutation. So these are the patients with multiple mutations. LV dysfunctions related to genotype. So if you look at the patients with LV dysfunction, phospholamban, desmoplakin are sort of the two where you see a lot of LV dysfunction. Plakophilin 2, only 16% of LV dysfunction. So it's very much linked to what the genetic abnormality is. Number 5, gender impacts phenotype. Presentation with sudden death is more common in men. Men are more likely to be probands. Among those presenting alive, arrhythmia-free survival is lower than men. Farad Duru and the group in Zurich have done some nice work with testosterone, and it turns out, testosterone's a bad actor, and if a higher level of testosterone, you have more active disease, higher risk of sudden death, and this accounts for, men having, dying suddenly more than women. So we'll move on to management. And I like to think about this 5-legged stool. You got to make the diagnosis. You got to figure out if they need a defibrillator. You need to minimize the defibrillator going off. You got to prevent progression. And then you have cascade family screening, because you got to think about other family members and diagnosing the disease early. So first, make a diagnosis. We've talked about that. The workup really is a history, a physical exam, an EKG. The single average EKG you can forget about. Holter's invaluable. Number of PVCs per 24 hours is very important, the diagnostic criteria. An echo or an MRI. Stress testing, not so much. We basically never do stress testing. There's a couple papers saying it can be of value, but generally we find these arrhythmias are not triggered on a stress test. It's sort of cumbersome to do, and we find it adds nothing or not, almost nothing. Genetic testing when the disease is suspected, and remember those task force criteria. So a couple new things, or relatively new things. Our colleagues in Bordeaux are really remarkable with their creativity. And this is a beautiful paper they took, where they took patients that had sort of ventricular ectopy, PVCs, 412 patients, and they did a high-dose isoproterenol infusion challenge, 45 mics per minute for 3 minutes. And what they reported in this study was that patients with ARVD have this kind of response. They just light up like a Christmas tree with reams of VT, multimorphic, triggered automatic VT, and the non-ARVD patients don't. They said this is a highly sensitive test for ARVC, and sort of called attention to this as a diagnostic test. You know, we've been doing it, and they're absolutely right. You see this. We sort of think of it more as a prognostic test. You know, if you're going to bring someone with possible ARVD, idiopathic VT to the lab for an ablation or risk stratification, always do this because it can provide you a better sense of what's going on. With typical idiopathic VT, you aren't going to see this kind of response. So I think it's a very useful test. That's important not to miss the opportunity to do this. A few other comments on diagnosis, because I didn't skip over it, about the epsilon wave. So we recently did a study, and I must have deleted it from the slide set, where we took 10 self-proclaimed experts in ARVD and sent them 30 EKGs and said, is there an epsilon wave or not? And it turns out no one could agree. And then we met and we agreed on a definition, and we did it again, and it still was horrific. So then, everyone's realized you only see epsilon waves in severe disease. And in severe disease, everything else is positive. So does the epsilon wave really add anything? So then we and a group in Norway looked at our databases and said, let's just delete epsilon waves from the diagnostic criteria and see how many patients go from diagnosis to be non-diagnosed. And basically it changed nothing, meaning you only see the epsilon wave, severe disease. By then all the other parameters are positive. So it really adds nothing. So basically, in your own mind, you shouldn't be looking for epsilon waves. You aren't going to be accurate in figuring it out, and it doesn't add anything. Just look at the other parameters, the Holter, the MRI, the genetics, the family history, that kind of stuff. So the next question is, do you need a defibrillator? And here are the variables that we think about: history of sustained VT or sudden death, proband status. If you're the proband, the first effect in the family, you're much higher risk than your family member. Male gender, we've talked about that. In general, more severe disease means higher risk. PV frequency on the Holter, more PVCs, higher risk. Cardiac syncope, exercise plans, results of EP testing. And then you got to filter this into whether a patient, what their threshold is for defibrillator. So Aditya Bansal and our group put together a nice series a number of years ago, 84 patients who got a primary prevention ICD. And you can see there's a reason we call it ARVD. 60% of patients that had appropriate shock within 5 years. There's no other condition you're going to see these kinds of curves. And even for VTVF, 30% by 6 years out, unbelievably arrhythmogenic, these patients. And the predictive factors were the results of EP testing. There's some debate about this. Domenico Corrado will say it's not predictive. We find it's predictive. The group in Zurich find it's predictive. It's one more test. If you can start up VT, you're more, that's a predictor in our mind. More than 1,000 PVCs as predictors, and the higher it goes, the higher the risk. Non-sustained VT separates them out, and proband status is very important. Family members are at much lower risk than the proband, so you can be much more selective and put in defibrillators in family members. Now, our latest big contribution to this is made by Julia Cadron-Teregni from Montreal, who came work with us for 2 years and put together this beautiful prediction model, sort of an app for risk in ARVC. And we worked with about 5 different ARVD registries to create a cohort of about 500 patients. And we looked at the predictors in our model were male gender, men higher risk, age. You're higher risk actually if you're younger than if you're older. Recent cardiac syncope is a risk factor. Non-sustained VT is a risk factor. PVC count, it's based, the higher the number, the higher the risk. Extent of disease based on T-wave inversions. And the RVF, we didn't end up including the LVF in the model because we had basically almost no patients that had that parameter. So it fell out as a predictor. And through that, we have an app. If you go to arvcrisk.com, you can put in age, number of T-wave inversions, number of PVCs, RVF, and you'll get a 5-year risk. Now, this risk calculator is for all arrhythmias. It's not for VF or V or rapid V flutter. It's for all VTs. So it sort of is overly sensitive, if you will, but it gives you sort of a general something, number to start the discussion with the patient. So just want to make you aware of that. Then the question becomes, should you get a sub-Q or get a standard defibrillator? And we're currently doing a study of the sub-Q device. I think we have 49 patients enrolled. We need one more. So if any of you have put a patient sub-Q device in an ARVD patient, we'd love to have that patient join our registry and be part of this little study. We can get across the finish line with 50. But the basic challenge is, unlike hypertrophic cardiomyopathy, where you have big voltages and big signals, with ARVD, you get myocyte loss and you get shrinking of the QRS complex and shrinking of the signals. So the real problem is inappropriate shocks because of T-wave sensing. So we've learned that it's effective, meaning we have a fair number of patients, 50, who've gotten a sub-Q device and none have died suddenly. So it's effective. But we've had a number, more patients got inappropriate shocks than with a standard device. And you have to balance that with the benefits of not having an endocardial lead. And in general, we've been using the sub-Q device sort of for primary prevention patients, even for 14, 50-year-olds, skinny little kids, where you want to avoid that lead. It's worked quite nicely. Once someone they're having sustained VT, not only do you lose the benefits of ATP, those are patients with more advanced disease, worse signals. You can still use it in those patients, but you got to be really circumspect to make sure they really pass all the vectors. Don't try to barely get them in by a little hair in terms of meeting the screening pairs when you put in the sub-Q ICD. So we like it. We're learning more. And it's great mainly for primary prevention, some secondary prevention, but just make sure the signals look good. Once you get it in, you want to minimize the shocks. So the main thing, and we're going to focus a lot on exercise and stop competitive and endurance sport, take beta blockers. We like giving patients ACE inhibitors if they have any evidence of structural disease. You can consider antiarrhythmic medications. If occurrence, and generally, they have ARVD, they have a lot of ectopy, you put them on a beta blocker, they still have a lot of ectopy and non-sustained VT. Then you think about sotalol or flecainide, they don't respond to that, they start having shocks. Then you think about catheter ablation, and we could talk more about that. So in terms of exercising, there's lots of data now saying you got to tell these people not to exercise. So we know it's a disease of the desmosomal dysfunction. We know these desmosomes are the glue that holds the heart together. We know when you exercise, the RV dilates and pressures increase threefold, so the wall stress in the RV goes up dramatically. The LV, there's less of an increase in wall stress. Most ARVD patients are high-level athletes. I mean, just yesterday, I was on the phone with a 14-year-old girl with newly diagnosed ARVD. And, a classic story. She was a swimmer since she was like 8, doing, 3 hours of swimming a day, had practice, was feeling bad after practice, threw up, went home, threw up some more, started looking bad, called 911, of course, was in VT at 220 beats a minute, and she's a 14-year-old with ARVD. EKG shows classic T-wave inversions. She has a plakophilin-2 mutation, and, we see this all the time. Exercise is a common trigger of arrhythmias and sudden death. There's now about 10 different exercise mouse models, and there's about 10 clinical studies showing how important this is. So this is the first major paper, one that my colleague Cindy James put together. 87 patients with a mutation, 56 endurance athletes, 31 not, and we took a lifetime exercise history. And what we found is the number of hours per year of exercise prior to presentation impacted whether they met diagnostic criteria. Again, all these patients had a mutation. So if you exercise 0 to 134 hours per week, only about a third had the disease. If you exercise 510 to 2,600 hours per week, 85% had the disease. Or if you said, are you an endurance athlete? Yes or no? If the answer is yes, 82%, no, 33%. And then that impacted their clinical course, freedom from sustained VT and heart failure. If you weren't an athlete, you didn't get heart failure. And if you were an athlete, a lot more likely to get heart failure. If you weren't an athlete, you're less likely to have VT than if you are an endurance athlete. So then our next big study was to look at patients who didn't have a mutation. And we did the same study in them, although we used met hours instead of just hours because we want to normalize for intensity. And what we found was fascinating. If you're gene elusive, no mutation, it took 6,700 met hours per year to get ARVC. Whereas if you had a gene, it only took 3,000, or a family history, it only took 3,000 met hours. So it's like the double hit hypothesis. If you have a mutation, less exercise added to that gets you the disease. If you don't have a mutation, some people have some predilection that with their super athletes, they get the condition. Now, this is a nice little study we did of PKP2 families where we took sort of a lifetime exercise history. Here's the program. This is lifetime met hours, like your odometer in your car. So the proband started at the age of 10, is exercising like heck, gets sustained VT, gets diagnosed with ARVD, stops exercising. And here's his siblings who have the same mutation but didn't exercise. These are the AHA recommended exercise. So you look at that, it's unbelievable. Here's another family, here's the proband. Unbelievable amounts of exercise, had sustained VT, got diagnosed with ARVD. No one told them to stop exercise until they came and saw us up here. So here's the siblings, fat and happy. Just kidding about fat. They're only fat if they're eating too many pizzas. But here's their AHA recommended level. But I think this really tells the story. And then we just got this paper accepted, which was fascinating, is we looked at patients with a mutation and we looked at all their exercise of those that got the disease and those that didn't get the disease. And this was fascinating because some patients, we hypothesized that if you did a lot of exercise and you had a mutation, you were going to get the disease, full stop. But what we found was some people get away with it. All these patients don't have the disease, but look how much they were exercising. So there's some factor that allows some people to get away with huge amounts of exercise. And we're now going to focus a study doing a whole genome, testing on these patients to figure out how were they so lucky where exercise didn't impact them, whereas all these patients, it obviously did. So more work to learn. Another paper we looked at was exercise restriction. And basically what we found is that patients who reduced their exercise the most were 86% less likely to get an appropriate ICD shock than if they didn't. So that's an unbelievable, powerful benefit of reducing your exercise dramatically. So for those of you who think you can keep exercising, you're misguided. So what's the role of catheter ablation? We talked about EP testing in a limited, you don't know if it's an idiopathic VT or ARVD in the beginning, go do an EP study. That will help figure it out, give them high-dose isoprel, it's idiopathic VT, ablate it. If they're positive with a high-dose isoprel and they have 5 different morphologies, it's probably not idiopathic VT. Catheter ablation is obviously recommended if you're getting frequent ICD therapies. And in some centers, it's reasonable to do it first line if you have a good experience and outcome. And Stubby can tell you how many VT ablations we do in ARVD here. I mean, my colleague Harry Tandrew does 2 or 3 a week, endo-epi. So it's an extremely common procedure here, but it's pretty rare other places. If multiple VT ablations fail, what do you do? And I'll go over a sort of an interesting case history. This guy, Sam, Mobile, Alabama, super ultra athlete, 50 triathlons since the age of 11. He was 16. You guys figure that out. Unbelievable athlete. So in March of 13, he felt lightheaded. He collapsed in the pool at a VF arrest, was resuscitated. He had some T-wave inversions looking like ARVD, but they thought this was long QT down there in Mobile, Alabama. They put a defibrillator in. He had some shocks. He had non-sustained VT, was sent here for management. We diagnosed ARVD. Look at this EKG, gorgeous, right? 16-year-old triathlete. Loads of ectopy, classic MRI, positive isoprel infusion test. So Harry goes and does an ablation. This is sort of where you tend to see the epicardial scar. Non-inducible discharge in a beta blocker, couldn't tolerate it. Had some PVCs, non-sustained VT, and we had recurrence within 6 months. So came back, he had another cardiac arrest, got multiple shocks, CPR for 16 minutes, hypothermia, came back, did another ablation. 2 morphologies induced, extensive ablation, negative EP study 3 days later, stress test shows some non-sustained VT. Had a shock a month later at a concert, non-sustained VT, started fleck-eyed. What did we do? Did we transplant him or do other things? So we said, well, let's send him up north to Penn. So he was sent up there. He went into VT, just entering the lab. Harry went up for this procedure to see what they were doing up there. Terminated with sedation, propofol. VT was induced, extensive endocardial ablation. They couldn't get into the epicardium because of scarring, so they opened his chest, did a cryo of the RV. So here's the cryo picture from up there at Penn, and we went all the way. Beautiful. negative EP study post-procedure. VT returned, 6 shocks for running to catch a flight 2 months later. More VT. What did we do next? Transplant or sympathectomy? He ended up getting a sympathectomy with Shiv Kumar. He went out to LA and he's had no arrhythmias since then. I think he went out to Shiv, or maybe we did it, I forget, but whatever, it worked. So since then, we've done this in about 18 or 20 ARVD patients. We wrote up a little paper about it recently, and we've had very good results. So it's sort of a last thing before transplant, and we're starting to do it a little bit earlier, bilateral sympathectomy, but we're learning more, and Harry's trying to figure out none ways to do this. So next, I want to talk about progression. First, I want to convince you that this is a progressive condition. I know there's some in our field think it's not, but they're wrong. You just think about it. No one's born with a disease. It shows up around puberty. So if it wasn't progressive, how could that happen? This is not a dysplasia, which is something you're born with. This is a cardiomyopathy which you develop. And it's not an acute event like a heart attack. It's a problem with intracellular connection that's ongoing. So we've done, we published a paper recently where we did echoes about 5 years apart, and guess what? Over time, RV function goes down, LV function goes down, and it's progressive. And we're seeing this now as we're seeing more and more patients who we followed for 20 years coming in for their transplant. So if you're just looking for a year or two, you'll think it's pretty stable. But if you look over a 2-decade view, you'll get a very clear view. It's progressive. Not in everybody. There's some John Campanellas in the world, like the first patient I presented. But for every John Campanella, there's another that's gearing up for a transplant. So this is another paper we put together looking at heart failure. So it turns out 49% of patients over time will develop heart failure symptoms. So again, it's a progressive condition. And this is just showing that. So how do you prevent progression? Stop exercising. Walking, golf is good. Sex is allowed for quality of life. But endurance sports is clearly out. What we don't know is, can you go walking? We think 2 to 3 days of light to moderate exercise is fine. We think weightlifting is better than running. We think that doing more than that is probably not wise till we learn more. There's a new document out that HRS put out on this consensus document on arrhythmogenic cardiomyopathy. And this is a very ambitious document that Jeff and Bill led. And they've basically redefined the field by saying arrhythmogenic cardiomyopathy is a twitchy heart. If you have evidence of heart disease and you have arrhythmias, then you have arrhythmogenic cardiomyopathy, and you should be evaluated or screened through an inherited heart disease kind of program. And because a lot of these patients will have diseases now. So the idea is, do you have ventricular dysfunction? Yes. Is it arrhythmia in the clinical presentation? Yes. Then the patient has ACM. Is another disorder present? Yes. So the things that fall into ACM now are sarcoidosis, Chagas disease, amyloidosis, sarcoidosis, myocarditis. And I think it's a way to sort of view people, but they're sort of taking a big tent approach. But arrhythmogenic cardiomyopathy is not really what we're talking about, ARVD, ALVD, that which are these desmosomal diseases. So it's sort of a ambitious sort of thought exercise, if you will. Now, before I draw things, well, let me just conclude, then I'm going to tell you the latest thing we're working on due to the virus. So ARVD is a rare disease, but it causes more sudden death than hypertrophic cardiomyopathy. It's a disease of desmosomal dysfunction. Making the diagnosis is challenging. You got to evaluate these patients carefully with non-invasive and invasive testing. We have a risk calculator to help guide decisions about defibrillator implantation, but family members, you're much less likely to need a defibrillator. Catheter ablation is important, but it's not curative. It's palliative. ARVD disease, it results in cardiac dysfunction. About half of patients with ARVD over time will get heart failure. We think ACE inhibitors is important. Exercise restrictions, very important for controlling arrhythmias, preventing progression. And we have this new term. Now, the final thing I'm going to talk to you about is some new data that we're about to submit, and it's sort of a new focus of the program. So the data that we're about to submit, a new paper, is over the time we've seen a number of patients that were initially diagnosed with myocarditis, and then ultimately they were diagnosed with ARVD. We have 12 patients in our series. And most of these patients have a desmoplakin mutation, but they show up with the myocarditis, chest pain, troponin leaks, and they're called myocarditis. And then 2, 3, 4 years later, it's clear they have ARVD, they have VT, they come in, they get whatever else, and desmoplakin seems to be the biggest player. But so that was sort of interesting. But one of the other interesting things we've been thinking about during the COVID shutdown is the overlap between ARVD and inflammation. And it's been known forever that about 2/3 of patients with ARVD have evidence of inflammatory cells on an autopsy or a biopsy or whatever. And people will talk about hot phases of ARVD where patients show up. You're like this girl I saw the other day. When she came in, she had a troponin, a high troponin. And that continued for about 2-3 weeks post her initial presentation. She's a plakophilin 2 patient. So she showed up in a hot phase where there's sort of active cell death going on. And over the years, we've seen a fair number of these patients where they come in, they have a troponin leak, they get worked up for ischemic disease, they don't have it, it turns out they have ARVD. So the real question is, how big of a role does inflammation play in the natural history of ARVD, these sort of hot phases? And how does one track this, monitor this, treat this? So we're sort of gearing up our new research focus to sort of look at this. I think the exercise story we've really nailed, we figured this out, and that's unbelievably important. But as that exercise figure shows, there's more to it than exercise. And I think inflammation probably is the next, and we know autonomics is important. We got that figured out. So I think the next big issue that we've got to sort out is inflammation. So stay tuned, but we're going to be, hopefully you'll see our paper soon that we're about to publish on this myocarditis stuff. And then we're going to be putting out a series of papers and hopefully doing some prospective studies of this sort of inflammatory component of ARVC and trying to better understand that. So I'll stop there, but let me just go to my final slides of, I want to thank my colleagues that are part of our program. Loads of people here at Hopkins work on ARVD these days. Our wonderful research fellows, and again, Harry Tandry was our first hire. What a genius we got with that recruit. And he's obviously the co-director of the program with me and has been fabulous. And again, we have wonderful genetic counselors here. We have 3 genetic counselors that are part of our full-time staff of our program. We're here to help. And we appreciate the opportunity to speak with all of you today in this online COVID world. Thanks so much. And I'll shut up.